distinguished guests, participants, ladies and gentlemen, on behalf of the organizing committee, it is my great honor to welcome you to the opening ceremony of the 14th TOTA 2026.
This year, we are delighted to host the Thai Orthopedic Trauma Annual Conference in our historic and beautiful city of Phitsanulok. We are beyond excited to welcome our best experts and colleagues who are dedicated to the field of orthopedics trauma care.
My name is Puwat Chinwatanawongwan.
And I am Ploy Pailin Rung Sakao.
We are truly honored to serve as your master of the ceremony in this event.
Over the next few days, this conference will provide a vibrant platform for academic exchange, collaboration, and innovation among orthopedic trauma surgeons from Thailand and around the world.
Without further delay, let us begin this special occasion.
To begin the ceremony, it is our pleasure to invite Associate Professor Kongkhet Riansuwan, President of the Thai Orthopedic Trauma Society, to present the official report of the Congress.
Please join us in welcoming Associate Professor Kongkhet Riansuwan to the stage.
Professor Geriatric Anterior, President of Royal College of Orthopedic Surgeons of Thailand, Dr. Manod Wutipong, Director of Puthachinaraj Hospital, Professor Dr. Supachai Pathumnakul, Permanent Secretary of the Ministry of Higher Education, Science, Research and Innovation, distinguished guests, ladies and gentlemen. On behalf of Thai Orthopedic Trauma Society, or TOTS, and the organizing committee, it's my great honor and privilege to present this report and to extend a warm welcome to all of you to Thai Orthopedic Trauma Annual Conference, or TOTA 2026 here in Phitsanulok. This meeting has been organized with the objective of bringing together professional and orthopedic surgeons from across the country, as well as international speakers and participants, to exchange knowledge, share experience, and explore innovative ideas that will contribute to sustainable development and future advancement in our field. So in this year, we are pleased to welcome almost 750 participants from different institutions, and along with 15 international speakers and guests. And we hope that this conference will provide a good opportunity for all of us for learning, collaboration, and professional connection. And we also hope that all of you will enjoy your time and your life here in Phitsanulok and experience its warm hospitality. And finally, I would like to express my sincere gratitude to our chairpersons for presiding over this opening ceremony, as well as all of the speakers and participants for your kind support. And now may I respectfully invite our chairperson to officially declare TOTA 2026 open. Thank you.
Thank you, Associate Professor Kongkhet Riansuwan, for your report.
Ladies and gentlemen, we will now proceed to the official opening ceremony.
It is now our great honor to invite Professor Geriatric Chonwanit, President of the Royal College of Orthopedic Surgeons of Thailand, to deliver the official opening address of the 14th TOTA.
Dear distinguished faculty, respect speaker and honor guests and dear participants. Today, we mark an important step forward for us. We come together to advance knowledge and elevate the standard of orthopedic trauma care. On behalf of Royal College of Orthopedic Surgeons of Thailand, it is my great honor and pleasure to warmly welcome all of you to the 14th TOTA Congress 2026. This Congress serves as an important platform that brings together expertise, experienced specialists, young surgeons, and healthcare providers, professionals to exchange your knowledge, your skill, and share clinical experience, and strengthening academic activity and collaboration. This year, scientific program highlight key and contemporary topics between the orthopedic trauma care, including complex trauma management, modern surgical technique, and complication management, along with the presidential lecture and international experts session. We hope that this session will not only enhance clinical practice, but also inspire new ideas and fostering stronger collaboration between all of us and all of institute and over the country. I would like to express my sincere appreciation for the organizing committee, distinguished speaker, sponsor, and all contributors for this dedicate in this making Congress possible. I wish you all for productive, rewarding, and inspiring experience. Welcome to the 14th TOTA Congress 2026. Thank you.
Thank you, Professor Geriatric, for the inspiring opening address.
Next up, we are honored to invite Dr. Manot Uwutipong, Director of Puthachinarath Hospital, to deliver a welcoming address.
Distinguished guests, honored speakers, college, and participants, ladies and gentlemen, it is my great honor and pleasure to warmly welcome all of you to the Thai Orthopedic Trauma Annual Congress, the annual scientific meeting of Orthopedic Trauma of Thailand. This congress serves as an important academic platform that brings together orthopedic surgeons, trauma specialists, and healthcare professionals from Thailand and abroad. It provides a valuable opportunity for us to exchange knowledge, share clinical experience, and discuss recent advanced, innovative techniques and best practice in orthopedic trauma care. Orthopedic trauma management continues to evolve rapidly. Continuous learning, collaboration, and the sharing of experts are essential to improve patient outcome and advance the quality of care. I strongly believe that the scientific session, lecture, and discussion throughout this congress will greatly contribute to professional development and inspire new perspectives among all participants. On behalf of Puthachinarath Hospital, I would like to express my appreciation to the Royal College of Orthopedic Surgeons of Thailand, the organizing committee, and all supporting partners for their dedication and hard work in making this congress possible. My heartfelt thanks also go to our distinguished speakers, both national and international, for sharing their valuable knowledge and experience. Finally, I wish all participants producing enriching and enjoyable congress, as well as pleasant stay here in Pittsburgh. With great pleasure, I now declare the TOTS Congress official open. Thank you very much.
Thank you, Dr. Manoj, for a warm welcoming speech. May we kindly ask Dr. Manoj to remain on the stage.
Now let us proceed to the official opening ceremony of TOTAC 2026.
And may we kindly invite distinguished guests, Professor Geriatric and Associate Professor Kongkhet to the stage as well.
What you are about to see here is a large model of a femur broken into 2 fragments and an intramedullary nail.
The femur, as the strongest bone in the body, often reflects the severity of trauma, require not only precision but also timely and coordination as well.
The intramedullary nail represents not only fixation of the fracture, but also the progress and innovation in trauma management, symbolizing our shared commitment to advancing trauma care.
Before the chairman strike the nail, let us count down together. Ready? 3, 2, 1.
What a fun and creative way to begin our conference. Following the ceremony, we will now present the official opening video of TOTAC 2026.
Kongkhet. Sriracha. Hot Yai. Chiang Mai. Korat. Pisanula. Welcome to 14th TOTAC 2026.
Next, we are honored to invite Associate Professor Saran Tantavisut, Chairman of the Academic Committee, to introduce the scientific program of this year, along with our distinguished international speakers.
Please welcome Associate Professor Saran Tantavisut.
Okay, sorry for a little bit of a technical problem. So, good morning, distinguished guests, respected faculty members, and dear colleagues. On behalf of the organizing committee, it's my great pleasure to welcome everyone to the 14th Thai Orthopedic Trauma Annual Conference 2026. This year, we are truly honored to have distinguished group of international experts joining us. Their contributions to orthopedic trauma surgery, research, and education have significantly advanced the field across Asia and around the world. Please allow me to introduce our invited speakers. From Korea, we are honored to welcome Professor Jong Hyun Oh, Professor Yong Shul Yoon, and Professor Seung Beom. From Taiwan, we are delighted to have Professor Yu Ping Su, Professor Kai Cheng Lin, and Professor Shun Cheng Lin. Representing Japan, Professor Tomohiro Matsumura. From China, Professor Su Ji. And from India, Professor Assoc Sunil Gavaskar. We sincerely thank all of the international speakers for taking the time to join us and for sharing their expertise with the orthopedic community here at TOTAC 2026. In addition, we are also pleased to welcome our exchange fellow who represent the spirit of international collaboration and academic exchange. Please welcome Dr. Lee Yang Kwa, Dr. Dae Yung Kwak, and Dr. Se Won Lee. Their participation highlights the importance of global cooperation, knowledge sharing, and professional friendship within orthopedic community. At this moment, may all of our distinguished international speakers and fellows may rise, please. Okay. So ladies and gentlemen, please join me giving a warm round of applause to all our international speakers and exchange fellows for being a part of TOTAC 2026. Thank you very much.
Thank you very much, Associate Professor Saran, for presenting an exciting academic program this year.
Looking ahead to the future of this Congress, we now proceed to the handover of the TOTAC symbol to the host of next year's conference.
May I invite Dr. Griangamon Benjawong Sathian, Head of Orthopedic Department, Pudachinnarat Hospital, and Assistant Professor Saran Marisorn, Head of Orthopedic Department, Faculty of Medicine, Riansuwan University, on the stage for us to present the TOTAC symbol.
And now may we invite the representatives of the TOTAC 27 host organization to receive the TOTAC symbol, please. Let's welcome Professor Thawichok Wisanu Yothin, Chief of Orthopedic Department, Faculty of Medicine, Kongkhet University, and Dr. Pongsathorn Laupakdi, Head of Orthopedic Department, Kongkhet Hospital.
Thank you very much.
Ladies and gentlemen, to welcome you to the next TOTAC conference, please enjoy the video presentation. Welcome to Kongkhet 2027.
Oh, Busan Kongkhet so beautiful. Diamond sun when I see you. Jangan Kongkhet to a wider view. Every district, every girl, my heart belongs to you. Nam today, she's incredible. Won't take your way, it's unforgettable. Shouldn't can take my eyes off you. Busan Kongkhet, my dream come true. again so beautiful. Joy and the sun when I see you. Yes, I'm down to this.
We will now begin the academic sessions of the Congress. Our first lecture of this morning is on Thailand research and innovation.
This lecture will be delivered by Prof.Supachai Pathumnakul, the Permanent Secretary of the Ministry of Higher Education, Science, Research and Innovation. Please join us in welcoming our speakers, Professor Supachai.
Good morning, Sawadee Krab. It's my great honor to be here for have a talk to this conference. I'm a little bit excited because this is the first time for me to talk in front of a lot of the medical doctors. My background is engineer. I do not have much experience in the medical education or medical research. So the topic that I would like to share with you is gonna be the big picture of the policy and the innovation ecosystem of Thailand. So now we are expect that we want to produce more the researchers and also the innovators in some of the focus area to increase the competitiveness of Thailand. Medical science is one of the field that we are very focused and give the importance to the area. So in my talk, so I would like to have some of the introductions of our ministry, the Ministry of Higher Education, Science, Research and Innovations, and go down to the BCG model and also the direction of the ministry. Since the ministry name is very long, the Ministry of Higher Education, Science, Research and Innovation. So the shortcut, we will call it the MHESI, the MHESI that represent the ministry name. The next one, I would like to talk about the biotech framework and the priority initiations. This framework is just a new framework that passed the National Council last year. That's going to be the roadmap for the research of Thailand related to the biotech framework that including the medical science. And the next one will be the medical innovation ecosystem and the example of the Thai medical innovation products and government incentives. And also the last one gonna be the potential collaboration program, that the forward commitment of the procurement. First, I would like to start a little bit about introduction of our ministry. The Ministry of Higher Education, Science, Research and Innovations, or the MHESI, that is the youngest ministry in Thailand. This coming May is going to have 7 years old. The ministry is at that time, the 7 years ago, the government at that time would like to merge between the higher education and the Ministry of Science and Technology and some of the research agency together. The purpose to create this new ministry, the main purpose is to increase the competitiveness of the country based on science, tech, and innovations. That's why we combine the Higher Education Commissions. 7 years ago, the Higher Education is under the Ministry of Education. Now we still have the Ministry of Education, but the higher education is spin out from the Ministry of Education to combine with the Ministry of Science and Tech, and also the Research Council to become the Ministry of Higher Education, Science, Research, and Innovation. That's the reason why the name of the ministry is very long. That is the longest ministry name in the country. And the structure of the ministry is a little bit complicated. You can see here, the top of the ministry, we have the council that called the National Higher Education, Science, Research, and Innovation Policy Council. Under for this council, our Prime Minister is the chair of the council. And also including many ministries under this council. The main functions of the Ministry of Higher Education, Science, Research, and Innovation, I can say like there are two legs, two main functions of the ministry. The first one here, this size, we do try to producing, we call the high skill workforce for the industry, for the country, to the capacity building, especially for the high skill workforce. The other side, that is the research side. We try to boost up the research and innovations of Thailand. So the two main functions of the ministry, that is for the people, for the workforce, the high-skilled workforce, and also the research. Under these two legs, we also have two funds. The two funds for the budget, we call the Higher Education Fund, and also the Science, Research, and Innovation Fund. Under the ministry, we oversee 154 universities in Thailand, both the public and the private. And also with the 14 research institutions under the ministry, and also seven funding agencies, program management units under the ministry. The ministry is the integrated, not just only the policy, but the funding, the implementation under the coordination nation framework. So these sides, they support the research, technology, innovation activities across the country. Mostly, I believe that more than 80% of the research funding of Thailand is under the research fund, under the seven of we call the PMU, the program management units. The next one I would like to talk is the BCG models. That is the new sustainable growth engine of Thailand. In recent years, Thailand has also adopted we call the bio, circular, and green economy model. We call it short like BCG model as a national development strategy. The BCG model focusing on creating value from biological resources, improving resource efficiency through the circular systems, and promoting environmentally sustainable economic growth. Within the bioeconomy pillar, the medical and healthcare industry is identified as one of the key sectors with high potential for innovation and value creation, both in health, medical sector and tourism and creative economy. You can see that from this is the bio. Medical technologies, biologies, pharmaceuticals, and medical devices are therefore considered part of the Thailand's emerging bioindustry. By investing in research and innovation in these areas, Thailand aims to create new economic opportunities while improving the health and the well-being of our populations under the BCG model, under this pillar, the platform of the technology. Thailand has established the National Science Research and Innovation Plan. The plan defines the strategic direction for research and innovation development. One of the most important priorities within the plan is strengthening the health security and developing the medical innovations. This includes support the R&D in vaccines, advanced therapy, medicinal products, medical devices, precision medicines, and other healthcare technologies. The goal is not only to improve the public health, but also to transform Thailand into a knowledge-based and high-value economy. That is the BCG model in health and wellness. So, how to advancing the tech-based economy in medical and healthcare? That is the opportunity of Thailand. Strengthening the healthcare, the medical and healthcare sector also enhance national resilience. Recent global events, including the pandemics and the geopolitical tensions, have clearly shown that the importance of healthcare self-reliance. Countries must have the capacity to produce essential medicines, vaccines, and medical equipment domestically. For Thailand, investing in the medical innovation will help ensure that our citizens have reliable access to medicines, to vaccine, to medical devices, and quality healthcare service. At the same time, developing a strong medical innovation industry will create a new job, supporting high-value industry and contribute positively to Thailand's economic growth. So I'd like to talk about the framework of the biotechnology industry development. That is a 10-year plan. This framework was approved by the Council at the end of last year. The National Higher Education Science Research and Innovation Policy Council, that the Prime Minister and the Chairman of the board, the Chairman of the councils, approved the biotechnology industry development framework for Thailand. This framework, the direction for developing the Thailand's biotechnology between the 2026 to 2035, that is a 10-year plan. One of the key target sectors within this framework is the advanced medicines. The framework emphasizes several strategic approaches. This established strong research and development consortia that bring together universities, research institutes, hospitals, and industry partners. Developing a highly skilled workforce capable to supporting advanced biotechnology and medical innovations, and also creating and enabling ecosystem that allows the entrepreneurs and researchers to translate their discoveries into products that can enter the market successfully. That is the high framework. And also for the policy initiatives under this framework, one important initiative under this framework is the development of the advanced medicines, including advanced therapy, medicinal products, or we call the ATMPs, and also the second phase of the Genomics Thailand projects. In the second phase, we aim to expand the genomic data infrastructure and support the precision medicines and the development of the medical devices manufactured by the Thai companies. Over the past few years, Thai manufacturers have begun producing increasingly sophisticated medical devices that meet international quality standards. So let's talk about the budget. So we, under the NSRF budget for the medical and health for 5 years, as I told you before, we have two funding. The first funding is for the higher education fund. That is for the workforce development. The second funding is for the research and innovation. That is the largest fund for the research in Thailand. Approximately is about 20 billion bahts a year for that budget. That is approximately $700 million. Even it's not much, but it's big enough to do something. And for the budget for the NSRF, for the 5 years, we have allocated nearly $400 million into the research and innovation in the medical and healthcare sector. This represents approximately the 13% of the total national research and innovation budget. Even it's not much, but it's not too small. The investment support the budget ranging from the basic research and technology development to the prototype creations, clinical testing, and the commercialization. Through this funding mechanism, Thailand has been able to accelerate the development of new medical technologies and strengthening collaboration between academia, industry, and the healthcare providers. Not just only the research. The ministry, under the plan, we also need to strengthening the innovative enterprise. Beyond the funding research, the ministry had also focused on strengthening the innovation ecosystem by increasing the investment in research and innovation through the mechanisms such as the university holding companies. Now in Thailand, we have changed the regulations, allow the Thai universities to create the holding company for the investment by its own. Currently, at least 12 universities have established the university holding company, enabling the creation of more than 100 startups and the spin-off companies under the universities. Developing the capabilities of entrepreneurs and innovation through the incubator, accelerators, and innovation-driven enterprise programs under the ministry. We support research and entrepreneurs in transform their idea into viable business, generating up to 1 billion baht in the revenues for the recent years. We also help to facilitate to expanding the market of innovation through the e-commerce for the e-commercials and innovation platform we call the ECIP. Where is it? Maybe. Oh, yeah. For the ECIP, which helps the connects innovative company and domestic and international market. Together, these initiatives and supporting measures, including the financial support, infrastructure, and human capital development incentives, and law and regulation revision, create an environment where innovation can grow from research to the commercialization. So the next will be the PMU. Someone in Thailand may be familiar with the PMU, the Program Management Units. That is the agency they are the organization that granting the budget for the research and innovations based on the topic, based on the area of the research and the innovation. The PMUs that support the have the financial support for the medical innovation across all of the technology readiness levels. So we may know that there are like 9 for the technology readiness level from the TRL1 until the to TRL9. The funding system in Thailand, we have the PMUs that can start from the PMU1 until the PMU9. Within the funding system, the PMU, the program management units, play a critical role managing research funding across the different stages of innovation development. Their support spans the entire medical innovation pipeline. From the early stage, that is from start TRL 3, 4, 5 or something. Start from the early stage concept development to the prototype development, the clinical validations, and also the market entry. Each PMU focus on a specific technology readiness level or the TRL, ensuring that the innovation receive appropriate support at the each stage of the innovation. In the future, Thailand may further strengthen this model by enabling certain PMUs to oversee specific industries from early stage to the commercialization, creating a more focus on integrated innovation ecosystem. That means maybe in the future, we can have the PMU just only for the medical innovation. Start from the beginning for the whole supply chains of the innovation in the medical innovation. That is the plan in the future. But now we still have just only 7, and we are going to have 2 more in the future. This year, gonna have the PMU for the military research and the PMU for the appropriate technology. But we may have the PMU that focus on medical innovation. That's possible, but it depends on the council and the study. Not only for supporting the money but the budget for doing the research and innovation. The Ministry Higher Education side research and innovation also responds to do the regulatory reform to accelerate the research utilization. In addition to the funding and the ecosystem development, regulatory frameworks are also extremely important for innovation, especially in Thailand. We have too many laws, we have too many of regulations. That is the obstacle for the creating the new products, new innovation in Thailand. So, recent years, the Ministry of Higher Education, one of our duty is to how to relax, how to reform the regulation to accelerate the research utilization. The Ministry of Higher Education had worked to improve the laws and regulation to facilitate the commercialization of research and innovation. One key example is the Thailand Research Innovation Utilization Promotion Act. Someone may know it if we call it the Try-Up Act. That is the act the same as someone may know about the Beom Act of the US. We also follow the Beom Act of the US, and to do it as the Thai version, then we call it the Try-Up Act. This law enables university and research institutions to transfer technology more efficiently for commercialization. Another regulation has been introduced to support the joint investment between public and private sector in research and innovation projects. This regulatory reform helps secure that research results can move more quickly from laboratories to the marketplace. The potential of Thai research and innovation in medical devices within the medical innovation landscape. Orthopedic research is one of the area with strong potential. Over the past few years, many research projects related to the orthopedic technologies have received funding from the national research programs. This project includes the development of implants, biomaterial, surgical instruments, and digital technologies that support orthopedic treatment. The collaboration between orthopedic surgeons, engineers, and researchers play a critical role in transforming clinical challenges into the innovation solution. These are goals for the development of medical devices. To guide the long-term development of Thailand medical device industry, the Ministry of Higher Education, Science, Research and Innovation had also developed a national white paper on medical device innovation. The strategy focused on three major categories. First, medical supplies and equipment used in the healthcare facilities. Second, medical devices designed for home use as particularly important in an aging society. The last one is the innovative and competitive medical technology that have strong export potential. We hope that, as I said before, in the future, more orthopedic innovation developed by Thai researchers will receive support from the National Research and Innovation Fund and successfully enter the both domestic and international market. Example of Thai innovation already used in the healthcare, right? For example, the Thai dental implant, liver fluke rapid test kit, the natural rubber stoma bag or something. This innovation have already been approved and adopted within the Thailand universal health coverage system. I mean, like in Thailand, we call the Supachai that can this product, that this innovative product can cover by Supachai, by the Thailand universal health coverage system. This is a very important milestone because it means that Thai innovations are not only being developed in laboratories, but are actually being used in hospitals and benefiting patients across the country. This success also reflects the strong collaboration between our ministry and the Ministry of Public Health. Our ministry plays a key role in supporting research, innovation and development, and the technology transfer, while the Ministry of Public Health provides the clinical environment, regulatory pathways, and healthcare system that enable these innovations to be tested, validated, and adopted in the real clinical settings. Looking ahead, our goal is to significantly increase the number of Thai medical innovation entering to the healthcare system. Government procurement policies also is very important. It's an important role in supporting medical innovation entering the healthcare system. The Thai government has introduced several procurement measures to support innovative products developed by Thai entrepreneurs, including the innovation list by the Budget Bureau and the NASDA. NASDA is the one of organization under our ministry, allows the government agency to procure this product through the specific procurement methods, helping innovative product enter the public sector market. Support the measure of the SMEs in the government procurement by the OSMEP SME. OSMEP is one of the organizations under the Thai government. Can receive, the SME manufacturer can receive up to 15% competitive advantage in government procurement. This measure help create an initial domestic market for innovative medical products as well, allowing Thai innovation to be adopted within our healthcare system. However, while the procurement incentives support the market at the downstream stage, it is also important to strengthen the connection between research, clinical needs, and the product development. The last one, for the potential collaboration program. So we call the forward commitment procurement, building a demand-driven medical innovation ecosystem. Forward commitment procurement is a model where the public sector identifies future innovation needs in advance and signals these needs to researchers and industry. This approach allows innovation to be developed based on the real demands from the healthcare providers rather than being driven only by the technology. For Thailand, this model highlights the importance of strong collaboration between the Ministry of Higher Education and the Ministry of Public Health. By listening to the needs of the hospitals, physicians, we can help guide researchers and entrepreneurs to develop technologies that directly address real clinical challenges. Through this collaborative approach, innovation becomes a process of co-creation. The co-creation where the researchers, clinicians, and industry works, the entrepreneur can work together from the early stage of the development, from the early stage of the R&D. Looking ahead, Thailand aims to build a demand-driven medical innovation ecosystem where the research institutions, healthcare providers, and industry collaboration to transform Thailand innovation to real solution for the patients. That is the policy of the Thai government under the Ministry of Higher Education, Science, Research, and Innovation. Try to help the researcher, try to promote the new technology in the healthcare system, and try to make it to market and the commercialization and the real use, real application. Thank you so much.
Thank you, Professor Supachai, for your insightful lecture. Our next session is the Korean Orthopedic Trauma Association Presidential Lecture.
We are honored to invite Professor Seung Han, President of Korean Orthopedic Trauma Association, to deliver this lecture. Please.
Okay, good morning, everybody. First of all, congratulations for this well-organized scientific meeting. I thank you, Thai Orthopedic Trauma Association, especially Dr. Kongkhet and Dr. People for nice arrangement. My topic is the management of geriatric acetabular fractures. This is the hospital I'm working for. Sorry. Okay. It's moving automatically moving. It's automatically moving. Slide is moving automatically. I know that. Yeah. Okay. Okay. Slide is automatically moving. Technical team. Okay. Okay. Anyway. It's okay. Okay. The geriatric acetabular fracture is a big problem in Korea because of the growing elderly population. So, it's a low energy trauma. 50% of the injury is by the fall from the standing height. Mortality rate is reported 8 to 25%. And generally, poor outcome is reported compared to those of the younger patients because of the negative influence of osteoporosis and multiple comorbidities. Oh my gosh. So main mechanism of injury is a fall onto posterior lateral side of the hip in greater trochanter. So basically it's a lateral compression injury. This mechanism drives the femoral head into the acetabulum with anteromedial force. So the consequence is anterior column fracture, femoral head medialization, and quadrilateral plate disruption, and posterior medial dome impaction. So the typical fracture pattern is mainly involves the anterior column, more than 50%, and the most column fracture is most common, 25%, and the anterior column and posterior hemi-T is 25%, and posterior column or wall fracture is rare. The common finding is multifragmentary fracture of quadrilateral plate and dome impaction and delamination of cartilage and subluxation. The poor physiological condition, the challenge is the poor physiological condition of the patient because of their elderly patient, and osteoporosis make fracture fixation difficult, and the comminution and dome impaction is another problem. So let me show the typical injury with cases. Female 76 years patient has a hypertension and DM, and the trauma is a slip down from her bed, and patient has previous I'm nailing on the left intertrochanteric fracture. You can see the osteoporosis there. You can see the quadrilateral plate is displaced medially. If there was no preoccupied femoral nail, there must be a fracture in the intertrochanter, but the load is transferred to the acetabulum. That's why the fracture happened in the acetabulum. This is a typical CT scan, and UT, okay. Okay, you can see the dome impression there. Okay, as a immediate post-op X-ray. I performed the inguinal approach, and you can see the spring plate on quadrilateral plate, because it's a more than 15 years ago case. At the time, the modified stop approach was not introduced. It's a post-op axial CT scan. You can see the quite well reduced fracture. The sagittal view. And post-op 1-year X-ray shows the well healing. There's no evidence of osteoarthritis. This is another case. It's a 88-year-old male, liver cirrhosis, slip down. And you can see that his T-score is -4, quite severe osteoporosis. It's initial X-ray, same pattern. The quadrilateral plate was medially displaced. And at the time, I used the modified stopper approach and the QRS plate system. You can see the quite well reduction of the fracture. The classification, we follows the conventional Judet-Litournel classification. And these are the treatment options for geriatric acetabular fracture. There's conservative management, open induction and internal fixation, percutaneous fixation, and acute or delayed total revasculoplasty. So, conservative management. We saved conservative management only for the patient with physiologically compromised and severely limited pre-injury mobility. And the fracture side, this is same as the acetabular fracture of younger patient, undisplaced and stable fracture, secondary congruency. But for conservative treatment, skeletal retraction is strongly not recommended because of the complication related to the long-term bed rest. And so early mobilization is recommended, especially for elderly patient. So there are no convincing evidence regarding the conservative treatment. Not many papers published, but in all the paper, 33% of elderly patients treated conservatively following acetabular fracture suffer from poor and unacceptable functional outcome. Let me show one of my painful cases. So 80-year-old lady has a brain aneurysm and the cerebral disease of her heart. But she is a independent community ambulator. She could go to the marketplace by herself. If you look at the X-ray, how do you think about that? Is conservative treatment is possible? You can see the dome impression there, but the otherwise major column displacement was not that bad. You can see the X-ray. Dome impaction was quite severe. Okay, you can see the posterior medial dome impaction. So I discussed with the patient and her family because she has many comorbidity. So they didn't want surgery. Me neither, because it's told. So 1 month later, you can see displacement was getting worse. And hip pain was aggravated. So I recommend bed rest and the total revasculoplasty after bony union. And what happened 3 months after trauma? The femur neck fracture was developed because of the femur head was captured by the narrowed acetabulum. So at the time, there was no other choice. So we needed bigger surgery. I reconstructed her hip with the cup cage construct, Coronoid cage, and total arthroplasty with the cochlear approach. So I regretted my decision. At that time, first time I had to perform the acetabular fracture fixation. And percutaneous fixation, there are not many papers about that. The problem of this fixation is technically demanding, accuracy reduction is nearly impossible, stability is still concerned, and higher mortality rate is reported in meta-analysis. So I usually don't recommend the percutaneous fixation for geriatric acetabular fracture. So main gold standard of the treatment is open reduction and internal fixation. So there are several challenges of the open reduction and internal fixation for geriatric fractures. The obtained reduction is not easy, and stable fixation and maintenance of reduction is sometimes difficult due to severe osteoporosis and higher rate of post-OP complication rate because of the patient comorbidity. Generally, the conversion rate to total arthroplasty is 20 to 30%. So the poor prognostic factor is the superior medial dome fragment, comminuted posterior fracture with marginal infection, tactile transverse fracture, and femoral head infection region, and significant subluxation. So the patient, we have to consider the patient should be optimized before surgery. We have to choose less invasive exposure. And we should understand the reduction and fixation strategy for osteoporotic bone. See, traditionally, the illuminal approach was the approach of choice, but it provides excellent direct visualization of anterior column, and we can handle the posterior column with this approach, but the problem is large amount of blood loss and lengthy operation time. So nowadays, we use modified stopper approach developed by original Dr. Claude Saji. I was lucky enough to participate in the cadaver workshop more than 10 years ago. The benefit is the less invasive direct visualization is of quadrilateral plate and the reduced operation time and reduced blood loss. So nowadays, I recommend this approach for many patients. For surgical tips, the use of proper retractor at proper site is very important. The P4, which need to be avoided, are obturated nerve injury, coronal mortis injury, and external iliac vessel injury, which is very dangerous, and the bleeding from the presacral venous plexus, just lateral to the SI joint. So I use the Pro system. I like the surgery retractor, the bayonet-shaped retractor, which is placed in just beneath the greater sciatic notch. It's very helpful. Sometimes we can use the light source there. Because of time limitation, I'll skip the video here. The sequence of reduction is the lateralization of the femoral head. I put a shunt screw through the femur neck and the head and pull it down, put it laterally, and reduce the loop. Stabilization of loop is very important. And the lateralized medial support, and then reduce the buttress and anterior wall. Then let me show the example of how to manage the dome impaction. You can see the dome impaction in the impaction there. And on the fluoroscopy control, I put the sharp elevator through the fracture line and push down the dome fragment, impacted dome fragment, and put some bone substitute or allograft there. And you can see the screw just above the impacted dome. We call it lifting screw. This example, it's 83 years male. This typical case. This CT scan. You can see whether it displaced quadrilateral plate, axial scan, and no infection. Posterior medial side. So I use a modified stop approach and the QRS plate like this. Post-operative, you can see the well-reduced the dome fragment. Right side is before surgery. 3 months. Okay, the open reduction internal fixation clinical outcome, the literature is still in debate, but nowadays, 83% of good and excellent result is reported in many series. Acute total vasoplasty with osteosynthesis, I would like to skip this technical part, but in some indication is expect poor fracture reduction, intra-articular comminution, and articular cartilage damage to femoral head, and pre-existing arthritis affecting hip, and combined femoral neck fracture. Or skip that. This case, combined femoral neck fracture. I use the modified stop approach and Coco-Langenberger approach together and fix the main column and total vasoplasty then. Delayed total vasoplasty is an indication. Clinical outcome is still in debate. In summary, the Acetabular fracture in elderly patients the management should be individualized by the prognostic, the patient factor and injury factor. We should choose optimal treatment. My take-home message is treatment should be individualized. Open reduction internal fixation is a gold standard. And lateralization of quadrilateral plate and reduction of dome infection are critical success factor. Anterior intrapelvic approach and QRS plate plays a great role for these fractures. Thank you for your attention.
Thank you very much, Professor Seung Han, for your educational lecture and for showing us some very interesting cases. Next up, we will have the Taiwan Orthopedic Trauma Association Presidential Lecture.
Please welcome Professor Yu Ping Su, President of Taiwan Orthopedic Trauma Association.
Good morning, Sawadee-ka. I'm Yu Ping Su from Thailand, Taiwan. Sorry. Taiwan was, I work in Taipei Veteran General Hospital. So, on behalf of Taiwan Trauma Associations, I would like to deliver my great appreciation to the leaderships and the working group for the TOTA 2026. It's my second time on this stage. So I begin to feel that actually I am also one of the member of the TOTS, right? So last year in Kauya TOTAC, I gave a talk about the management of major bone defect. But this year I would like to share a talk. I hope it's still relatively new. It's Coronoid first with direct anterior approach for elbow fracture dislocations. I'm going to share with you our preliminary experience, and I will suggest it is a reliable protocol. So today's outlines, I will briefly cover the role of coronoid process and the anterior capsules in elbow stability. And I also explain that there is a diversity of injury mechanism in elbow fracture dislocations. I will introduce how we do the E-way-based decision makings and how we do the elbow DAA, and I will provide some of our clinical results. So we all know that the elbow fracture dislocation is very notorious about its poor outcomes with the recurrent dislocation, joint stiffness, post-traumatic arthritis, and the reason for that majorly come from coronoid neglections, failure of fixations, radial hand mount management, including maybe the failed osteosynthesis or the poor sizing of the prosthesis. And inadequate soft tissue repair and loss of ulnar anatomy also belong to this field. But today I would like to focus on the coronoid issues. As we know that the elbow stability relies on the synergist constraints from the osseous ligaments and the muscular structures. And the ulnar humeral joint is the main source of bony stability. And as a part of this structure, the coronoid process provides the strongest anterior buttress to prevent the ulna from posterior dislocation, especially when the elbow is placed at 90-degree flexions. But when we extend the forearm, actually it diminishes along with the range of motion. Then the sublime tubercle is the insertion of the MCL anterior bundles, which provide the resistance to varus and external rotation, especially when the elbow is also put in 90 degrees. So since the coronoid process serves as very important pivotal stones of normal range of motions, it actually acts as a fulcrum of leverage when we get the injury from fracture dislocation. So we can borrow from the fracture pattern of coronoid process. We can interpret the mechanism or even to interpret the soft tissue injury of the soft tissue degree of soft tissue injury. So like the PLI used to be described as very difficult, very common classics and mechanisms of the terrible triads. More first of all, the rotatory force, and the last degree, the bony injury. So in O'Driscoll type 1 tip fractures usually is a key feature for this PLRI. On the other hand, the PVMRI or PMRI actually delivers a varus loads and open the lateral space. And it's usually the bony structure, the bony injury is less compared to the PLRI, but usually feature with the anterior medial facet injury. So the coronoid process is so important that even you have intact collateral ligament, but a compromised coronoid such as anterior medial facet could compromise all the stability of the elbows. So while the coronoid process actually have been focused on, the role of the joint capsule actually gets less attention. But there is a bunch of studies to study on the role of the joint capsule for the elbow stability, but never been emphasized. The anterior capsule actually blending with the LCL complex and the MCL complex, and then they form three condensed bands, and it provides it serves as a passive stabilizer, but it also provides the proprioception to protect the joints. It is very important contributor to the elbow state stabilization when the elbow is put in the fully extension to semi flexions. And I want to highlight this position because this position is the most common angle that we get the elbow injury. So specific mechanism of fracture dislocations can bring the specific pattern of capsule injury, such as the PMRI will bring the injury to the medial and the posterior medial capsules. Acute valgus injury will cause the torn medial and anterior capsule. In PLRI, they usually have lateral and anterior capsule torns. So this is a nice study, beautiful study from Japan. The cadaversis study that shows that there is an osseous capsular ligament and muscular aponeurosis complex around the elbow. So this structure actually interacts and work as a functional whole to protect our elbows from injury during the sports. And I from my idea, I think to rebuild the integrity of the capsule around the coronoid actually would help to improve the outcomes of this treatment. But we all agree that the fracture mechanism could be mixed in the injury, so that the fracture pattern is not exclusively indicative of just one mechanism. And given the terrible triad as an example, that we know that classically it is from PRI, but the study based on the CT image that's shown, it also has 1/3 of cases featured with mechanism from PMRI. And this is a nice study from Korean. They used the tear patterns, the tear pattern of the soft tissue and the bone bruise to interpret the mechanisms of the injury. And I think they suggest another injury is a PMER, no other than PLRI and the PVMRI. So we all know that if we if we just use the fracture pattern to interpret the soft tissue injury, we might have the chance to underestimate the degrees of soft tissue injury. So mini bone injury doesn't equate to minimal soft tissue injury. So in clinical practice, we either close follow up the patient or we put the patient into the OR for EUA. And this in our hospital, the EUA, run like in a structured format. After close reduction, we check through the quality and the congruence of the reduction throughout the range of motion between 30 degrees to 120. And we gently reproduce the mechanism of the injury by checking the posterior lateral pubis sheath and the varus drop arms. So when the ulnar humeral joint is put in the relatively stable, we check the spination and pronation to see the difference in the space between capitulum and radial head. And we also, with the forearm in pronation, and we check the varus and the valgus to check the medial and lateral side collateral ligament. So coronoid fixation remains as a center of controversy due to the fact actually the treatment outcome is suboptimal. So it remains the controversy focus on the indication and sequence and the approach. So maybe I will explain about the approach later. So I think based on the understanding that the importance of coronoid process and anterior capsule, I think, to directly treat the coronoid process through the DA approach would bring the insights to this field and have the potential to improve the outcome. So talk about the approach. The data approach is the most common used and have been reported to have very good outcome in the past. And the advantage is that it can provide one incision for two lesions, but actually it gives I think insufficient exposure to the coronoid process and then have challenge for fixation. Either you use the push through suture, you can retrograde screw to catch but it is very difficult. It's not allowed the buttress place. And for the medial approach is also like the advantage is that you can access the sublime tubercle directly and have been reported to have good outcome. But the issue is, no matter you use a relatively limited muscle splitting or you use the Hotchkiss over the top or you use the extended medial approach, it is just too extensive to get the good exposure. And the posterior global approach, it can provide the access to both the radial head and the collateral process at the same incision. But again, it's very extensive. So what do we do? The elbow DAA is like we start a S-shaped incisions in front of the flexion crease, and you cut the lacetus fibrosis is the biceps aponeurosis open, and you retract the biceps belly laterally, and you will find and palpate the brachial artery and the median nerve by palpation and the acute and blunt dissections. So, unlike the traditional way, the way we are doing is we go into the interval between the median nerve and the brachial artery. And that's, by pulling the brachial artery together with the bicep belly, you can easily to access the brachialis muscle. And you just split it, or you can do a little bit, elevation that you can reach the joints. And it give you access, laterally to the sublime tubercle, the roof, and laterally to the medial part of the capitulum. So this is case, Ostrisco type 2-3, that means the sublime tubercle is broken and it's a Manson type 1. So what do we do? This is a case I use to introduce our EUA. So after reduction I fix the tiny parts of the coronoid, and I use a suture anchor to repair, to catch the capsule, and I also use another suture anchor to capture the sublime tubercle to restore the stability of the medial side. That is how it looks like. Another case is O'Driscoll type 2-2. That means the sublime tubercle is intact. The radial head is Manson type 2. So again, in this case, I use the compact handset mini place, to cover all the coronoids, and I go back to the lateral incision to fix the radial heads. And this is another case. It is Manson type 3 of the radial head. You can argue on that, but we still fix the case. I mean, you can give me comment on the radial head because there is non-union, but I use this case to demonstrate that even with the existence of a radial head fixation failure, the patient still, are functioning very good because of good stability from the ulnar humeral joints. So we publish our paper that we exclusively include the terrible triads, and at the 2 years clinical outcome, I think is very good, very satisfied for us. And in our cases, actually, we have injury from POI and the PMI, and all. I think it all works good. So I think in direct anterior approach of the elbow, the advantage is it provides a wide indication for coronoid fractures. And it gives you a bird eye view for the whole, the whole coronoid. You can evaluate the fracture patterns. And you can confirm the ideal ulnar humeral reduction just underneath your eyes. And you can keep the positions to fix this. You don't need I think the best part, you don't need to twist it or rotate it to fix the elbow. And then you can easily, go back to the lateral side for your radius. So it's a lot of perpendicular buttress fixations, the minimal soft tissue stripping and detachment, and less scarring over the elbows. But it also, the indication is wide, but I think it's not suitable for the basal type 2 because it's very comminuted along with the ulnar fractures. But I think it is also good for capitarum coronal shear fractures. It also have a limitation that it cannot, it provides just an indirect access for subline tubercle. And it is not indicated for associated olecranon or ulnar shear fractures. So on this picture, you can see the line, you can measure, you get a very, very good firm reductions during the surgery. This is a case of capitarum trochlear coronoid shear fractures. I think this approach is also very suitable for this fracture pattern. So my message today is structured EUA is practical and reliable for your decision makings, for not to under evaluations, underestimate the soft tissue injury. And the coronoid first policy ensure reduction and the stability for the major elbow stabilizer. DA or elbows provide technical and biomechanical advantage for coronoid fixation. But indeed, or more study look into this part regarding as more patient, more fracture pattern, and the biomechanical study will be needed. So I would like to have a promotion here. I welcome all of you if any chances come visit us July 25th to 26th. Will be a annual meeting of TOTA. I want to host you all in Taipei. And again, thanks for having me here in this great event. Thank you so much. Thank you.
Thank you very much, Professor Yu Bing-Su, for sharing us your insights and experiences.
This concludes our opening session. Next, we will proceed to the group photo session.
The photo sessions will be conducted in 2 rounds. First up will be our senior faculty members and international speakers.
And after that, we will take a second photo, including all of the faculty members. May we kindly ask all of the international guests to remain here for the group photo first. And please following the diagram display on the screen to see where you stand.
Senior faculty members and international speakers, please come up to the stage for a group photo.
And all participants, please proceed outside of this conference hall. The room will be reconfigured into 2 separate sessions after this for the upcoming scientific session. Thank you.
Thank you, everyone. We invite all participants to enjoy the coffee break outside. faculty members, please come up to the stage for the group photo. Senior members and international speakers, please remain on the stage. Can we please have senior faculty members and international guests back on the stage, please, for the complete group photo?